You are tired. Not just end of the day tired. The kind of tired that is there when you wake up, that does not improve after coffee, that makes a full night of sleep feel like it accomplished nothing. You are short of breath climbing stairs you climbed easily 2 years ago. Your heart races doing things that never used to raise your pulse. And when you mentioned it to your doctor, your blood work came back and they said everything looks fine. Here's what they probably did not check. Or if they checked it, what they probably did not interpret correctly. Your iron. Not just your hemoglobin, your actual iron stores. And in most adults over 40, especially women, iron deficiency is running silently for years before it shows up on a standard blood panel. I'm going to show you exactly what low iron does inside your body, why the standard blood test misses it, and the specific signs that tell you something is wrong before the numbers catch up. Comment below. Do you feel tired all the time, even when you sleep enough? And if this is the kind of health information you have been looking for, hit subscribe. Every week I publish what your doctor does not have time to explain. Most people think of iron as something to do with anemia. Low iron equals anemia. Anemia equals pale and tired. Take a supplement and move on. That picture is incomplete in a way that matters enormously. Iron does not just make red blood cells. It is involved in over 200 enzymatic reactions in the human body. It is essential for producing ATP, the molecule your cells use as fuel for everything they do. It is required for proper thyroid function, for the production of neurotransmitters including dopamine and serotonin, and for maintaining the myelin sheath that insulates nerve fibers and allows signals to travel through the nervous system at full speed. Think of iron like the electricity supply to a building. When the power is fully on, every system runs normally. The lights, the heating, the elevators, the computers. When the power is reduced but not cut off entirely, some things still work. But the heating is less efficient, the elevators are slower, the computers take longer to process. The building is still standing, but it is not running properly. And the people inside it feel the difference even if they cannot point to exactly what is wrong. That is iron deficiency before anemia. The system is still running, but it is running on reduced power. And the symptoms, fatigue, brain fog, shortness of breath, cold hands and feet, hair loss, restless legs, are the body telling you that something is using less electricity than it should. After 40, several things happen simultaneously that make iron deficiency more likely and harder to catch. Absorption decreases as stomach acid production naturally declines with age, and stomach acid is essential for converting the iron in food into the form the body can absorb. For women still menstruating, monthly blood loss continues. For both men and women, chronic low-grade inflammation, which becomes more common after 40, actively suppresses iron absorption as a protective mechanism. The body thinks it is fighting an infection and locks iron away where bacteria cannot access it. The result is a slow, progressive depletion that can go on for years. Here's the piece that frustrates me most in clinical practice. A patient comes in with classic iron deficiency symptoms: exhaustion, brain fog, shortness of breath, heart palpitations. The doctor orders a complete blood count. The hemoglobin comes back normal. The doctor says your blood work is fine and sends the patient home. But hemoglobin is a late marker. By the time hemoglobin drops, iron deficiency has usually been present for months, sometimes years. The body protects hemoglobin until it cannot anymore. It is too important for oxygen delivery. So the hemoglobin number stays normal while everything else suffers. Think of it like a fuel gauge that only registers empty when you have been running on fumes for the last 50 miles. The gauge looks fine, but you ran out of fuel a long time ago. The test that actually tells you what is happening earlier is ferritin. Ferritin is the protein that stores iron in the body. When iron levels start to drop, the body draws from its ferritin stores before hemoglobin is affected. Ferritin is the reserve tank, and ferritin can be nearly empty while hemoglobin is still technically normal. A 2021 study in the Journal of Internal Medicine found that adults with ferritin levels below 30 micrograms per liter reported significant fatigue, cognitive impairment, and reduced exercise tolerance, even when their hemoglobin was completely within the normal range. The symptoms were real. The standard blood test would have shown nothing wrong. The reference range for ferritin on most lab reports is 12 to 300 micrograms per liter for women, 30 to 400 for men. If your result comes back at 15 and the lab marks it as normal, technically it is within range. But clinically, a ferritin of 15 is consistent with depleted iron stores and is associated with the full range of iron deficiency symptoms. When you look at your blood results, do not just look at whether the number falls within the reference range. Look at where in that range it falls. A ferritin of 15 is not the same as a ferritin of 150, even if both are marked normal. Stay with me, because what I am about to tell you about the signs of low iron is going to sound familiar in a way that most doctors never connect. The symptoms of iron deficiency before anemia are not dramatic. They are subtle, gradual, and easy to attribute to something else: stress, age, poor sleep, being out of shape. This is exactly why they go unrecognized for so long. The first and most consistent symptom is fatigue that does not respond to rest, not tiredness from exertion, a baseline heaviness that is there from the moment you wake up. Iron is required for mitochondrial function, the process by which your cells produce energy. Without sufficient iron, every cell in your body is producing less ATP than it should. The result is not just physical fatigue, it is a cellular energy deficit that affects every system simultaneously. The second symptom is brain fog. Difficulty concentrating, slower processing, words that take longer to come, tasks that require more effort than they used to. Dopamine synthesis requires iron. When iron is low, dopamine production drops, and dopamine is the neurotransmitter most responsible for focus, motivation, and cognitive speed. This is not weakness or laziness. It is chemistry. The third symptom is shortness of breath on exertion. Even before hemoglobin drops significantly, reduced iron availability affects the efficiency of oxygen use inside cells. A flight of stairs that used to be effortless now leaves you winded. A walk that used to be pleasant now requires recovery. Your cardiovascular system is working harder to compensate. The fourth symptom is heart palpitations, an awareness of your heartbeat, occasional racing, fluttering sensations. When oxygen delivery is slightly reduced, the heart compensates by beating faster and harder. Most patients with this symptom get sent for cardiac investigation. The heart is fine. The iron is not. The fifth is cold hands and feet. Even in warm environments, iron is required for proper circulation and for maintaining peripheral blood flow. When iron is low, the body prioritizes blood flow to vital organs and reduces it to the extremities. I had a patient, Maria, 44, a nurse from Phoenix. She came to me with exhaustion, brain fog, and palpitations that had been building for 2 years. She had seen 3 doctors. Her hemoglobin was 12.8, low normal for a woman, but technically within range. Nobody had checked her ferritin. When we tested it, her ferritin was 9. She had been running on essentially empty iron stores for what was likely 2 years or more. We started iron supplementation and addressed her absorption. 8 weeks later, her ferritin had risen to 42. Her energy was, in her words, unrecognizable. The brain fog had cleared, the palpitations had stopped, same body, same diet, same life, just iron at a level that allowed her physiology to function. If any of this is sounding familiar, the tiredness, the fog, the shortness of breath, hit the like button. It helps this video reach people who have been told their blood work is fine when it is not. Iron deficiency is not equally distributed. Certain patterns after 40 dramatically increase the risk, and most of them are not on the standard checklist doctors run through. The first is reduced stomach acid. Hydrochloric acid in the stomach converts ferric iron, the form found in plant foods and supplements, into ferrous iron, which the body can absorb. After 40, stomach acid production naturally declines. This is a physiological change, not a disease, but it means that even if you are eating adequate iron, you may be absorbing a significantly smaller fraction of it than you were at 30. This effect is dramatically amplified if you take proton pump inhibitors, medications like omeprazole or pantoprazole prescribed for acid reflux. These drugs suppress stomach acid intentionally. A 2020 study in Alimentary Pharmacology and Therapeutics found that long-term proton pump inhibitor use was associated with a 2.6-fold increased risk of iron deficiency anemia. 2.6 times. Most patients on these medications are never warned about this. Think of proton pump inhibitors like putting a lock on the door that iron needs to walk through. The iron is arriving, but the door is closed, and nobody told you the door was closed. The second risk factor is chronic inflammation. Inflammation from any source, including obesity, autoimmune conditions, dental disease, or chronic stress, triggers the release of a hormone called hepcidin. Hepcidin is the body's iron gatekeeper. When hepcidin levels are high, the body blocks iron absorption from the gut and locks iron inside storage cells. The body thinks it is fighting an infection and is deliberately withholding iron. But in chronic low-grade inflammation, this response is triggered continuously, creating a state where iron is theoretically present but functionally unavailable. The third is dietary shift. Many adults over 40 reduce red meat consumption for health reasons. Red meat contains heme iron, the most bioavailable form, absorbed at a rate of 15 to 35%. Plant-based iron is non-heme iron, absorbed at 2 to 10%. If you have shifted significantly away from animal protein without paying attention to iron intake, your absorption may have dropped substantially. A 2022 study in Nutrients found that adults over 40 who had reduced red meat consumption for more than 5 years showed ferritin levels on average 40% lower than those who had maintained moderate red meat intake. 40% lower ferritin from a dietary change most people made thinking they were improving their health. Here's what to actually do if you suspect your iron is low. And I want to be specific because the standard approach leaves too much on the table. Ask your doctor for a full iron panel, not just a complete blood count. The panel should include ferritin, serum iron, total iron binding capacity, and transferrin saturation. These 4 numbers together give you a complete picture of your iron status. Any one of them in isolation can be misleading. Together, they tell the full story. Specifically, ask for your ferritin number, not just whether it is in range, but the actual number. A ferritin below 50 micrograms per liter is associated with symptoms in many individuals. A ferritin below 30 is considered iron depleted by most functional medicine practitioners, even if it falls within the standard reference range. A ferritin below 12 is universally considered deficient. If your ferritin comes back between 12 and 30 and you have symptoms, that number is almost certainly contributing to how you feel. Do not accept your results are normal as the end of the conversation. On the dietary side, 3 changes make a measurable difference. First, pair iron-rich foods with vitamin C. Vitamin C converts non-heme iron into the absorbable form. A glass of orange juice with your iron-rich meal, or bell peppers alongside lentils or spinach, increases non-heme iron absorption by up to 300%. 300% from a dietary pairing that costs nothing. Second, separate iron-rich foods from calcium-rich foods. Calcium directly competes with iron for absorption at the intestinal level. Milk, cheese, and yogurt consumed in the same meal as iron-rich foods can reduce iron absorption by up to 50%. Not forever, not permanently, just at that meal. Separating them by 2 hours removes the competition entirely. Third, if you take a proton pump inhibitor and your ferritin is low, this is a conversation worth having with your prescribing physician. There may be alternatives or a plan to reassess whether long-term acid suppression is still necessary. If supplementation is appropriate, and this is a conversation to have with your doctor based on your specific results, iron bisglycinate is generally better tolerated than ferrous sulfate, causes less gastrointestinal side effects, and has comparable or superior absorption. Taking it on an empty stomach with vitamin C maximizes absorption. Taking it every other day rather than daily has been shown in research to produce higher absorption rates because daily dosing temporarily elevates hepcidin, which blocks the next day's dose. Every other day, with vitamin C, on an empty stomach if tolerated. That is not intuitive, but that is what the research shows. Your fatigue is not just age. Your brain fog is not just stress. Your shortness of breath on the stairs is not just fitness. In a significant proportion of adults over 40, these symptoms have a specific measurable treatable cause, and it starts with a ferritin number that most doctors never check. Ask for the full iron panel. Get your ferritin number. Pair iron with vitamin C. Separate it from calcium. And if you are on a proton pump inhibitor, that is a conversation worth having. If you want to know which specific nutrient deficiency is making your iron deficiency worse and is almost never tested on standard blood work,